All right, good afternoon. What a wonderful plenary that was. Shout out to both of those speakers. They were fantastic. Thank you all so much for coming to our Reproductive Health and Parenting and the Modern Era of CF. We have 3 dynamic speakers plus a patient who we pre-recorded who's going to be sharing his story with his wife. And so here are our lovely speakers. So we're going to start with Tyler and Darby, Tyler's one of my patients from Johns Hopkins, who's going to give his patient perspective in reproductive health, and Darby's going to be there to help tell their story. And then we have Dr. Tracy Kazmersky, Dr. Raksha Jain, and Dr. Chris Fortner, and we will be introducing them individually. So we will start with our patient story.
Hi, Tyler and Darby. Thank you so much for taking the time to tell your story to our audience. I have to start off by first saying, happy anniversary, 4 years, right?
Yeah, thank you.
Although we have recorded this a few weeks before NACFC, I would like to introduce you guys to our colleagues who are now listening live to NACFC. We just want to really thank you for joining us, everyone. This is Tyler and Darby Smith, who are going to share their journey about becoming a parent. And Tyler, you're the one with CF, and so maybe if you could take a moment to tell us a little bit about yourself. I know that having a lung transplant is a big part of your life and the story. So if you can tell us a little bit about that, that would be great.
Yeah, of course. So in 2018, I was doing very well health-wise, and things very quickly changed. That it was every couple of months I was in and out of Hopkins, needing a tune-up and IVs. And this went on for about 6 months or so, towards the end of 2017 and then leading into 2018. And we got to the point where transplant talk had to happen. Wasn't quite ready for it, but the team at Hopkins, Dr. West and Dr. Bush made it a very easy decision, a logical decision, and it was a tough time to get through, but it was very well worth it to see where we are at today.
And I think if you can remind me, there was about a certain date that was going around that had to be changed.
Yep. So we had to push our wedding, which was supposed to be in September, up to June, which was when transplant happened. So after all was said and done, we had 5 wedding dates. We had the original of September, we had 2 in June, or 3 in June, and then we had 1 more, which was our final one in October of 2018.
And when was your transplant?
June 22nd of 2018.
Okay, great. So not to give a spoiler alert, but you now have a little girl named Paisley. But before we get to her and how she came to be in your life, can you tell me if you and Darby had considered children before transplant, and perhaps maybe what changed after transplant?
There were conversations. For me, it was very much that I never really wanted to have that thought in my head because I didn't want to get my hopes up, knowing that, you know, with my health, I may not be here to see a child. And I didn't want to go into a relationship with someone thinking that, oh, we're going to have kids because we both want it. But there was a huge possibility that I couldn't have children. So with us, I think very much having the health after transplant, going from 16% FEV1 to 101% today, I think was a huge jump and boost in wanting to pursue children.
And Darby, if I can ask you, what was your conversations and thought process? Because you guys met early on in life.
We did. We met freshman year of high school. Yeah, so I knew I always wanted kids. I never really had a number in mind. I just knew I wanted kids. When I met Tyler, he kind of gave me the rundown of CF and what that involves and what that entails, and the possibility or not possibility of kids. So that was a bit of information to take in. It was kind of a shock to me. So I had to rethink my future a little bit, but when Tyler, sorry, I'm gonna cry. This whole thing's been just a crazy whirlwind. When Tyler became healthy again, the talks of children came back up, and we were so happy. We got right on it. We were ready.
And I remember when you guys came to CF Clinic and kind of had that first conversation, and this was after transplant, obviously, and I was so happy. So can you tell us how maybe our team, the transplant team, how was that process to get you to where you needed to be information-wise?
Well, I originally started to talk with my transplant team, and they said as long as you're fully healthy and you have viable sperm, that you should be able to have kids through in vitro fertilization. But they said for more information to reach out to you guys on my CF team. And like you said, we came in and we had a talk and kind of gave you a rundown of why males with CF were most likely infertile. And you gave us, here's your next step of, you go talk to a fertility clinic, get a evaluation done and see what your options are from there. And we reached out to Shady Grove and we just went from there, and it turned into a great miracle.
I even think you helped the process get started a little bit, because I kind of remember you handing Tyler a little doggy bag as we left your office, saying, drop this off at the fertility clinic. It was a good memory. It was so funny. It was so positive that you guys helped get us going and get those conversations going. So it's funny now. It's funny to think about it now, but yeah.
I love it. And I can foresee that everyone at NACFC is laughing right now. So start laughing, guys, colleagues, if you're not already. One question though, what made you decide on that in terms of whether it was like surrogacy, adoption, all the different options of being a parent? What made you decide to go for in vitro?
Well, I think for me, when the thought of children was a possibility, I wanted it to be my own if it was a possibility. We had talked before, and financials were a hard part of it. And we talked and talked and talked, and it turned into, well, if we can have our own, we want it that way. But we were not closing our minds to second options of adoption or surrogacy if possible.
Absolutely. And then I know there were some bumps along the road. Mm-hmm. If you don't mind sharing whatever you are comfortable sharing, tell us about the process of everything, maybe starting from Tyler, your procedure, to Darby, everything you had to go through.
Yeah. Well, a big start for us in this whole process was figuring out if we could actually afford it. Was it in our eyes worth the chance of losing a lot of money to potentially end up with nothing, or at the end of it, money wasn't something that we were extremely worried about if we could get a child out of it. We very much talked a lot and exhausted every option we had. We were doing research to see if there was any grants or there was any financial help. I even went to Josie Schaefer from the Cystic Fibrosis Foundation and talked to her about if the foundation offered any assistance, as we're coming closer to a cure with CF, and we want to start helping those secondary groups, and not only a cure, but helping make transplant post-life a lot better as well, if there was something that they offered, and unfortunately we didn't. So what we had to rely on was pinching our pennies, not purchasing things that weren't necessary, and we relied very, very heavily on financial support from both sets of grandparents and parents. And sorry, this part's really hard for me because my grandmother, who very much wanted to meet her, passed away 6 months before she was born. But I know she kept an eye on her until she got here.
Absolutely. Oh gosh, that's really heavy, and I really appreciate you sharing that part. I think that the financial part of this is very important, and so for our social workers and nurses and physicians in the audience, just keeping that in mind for our CF community is very important, and I appreciate you sharing that aspect.
Mm-hmm.
Tyler, if I can start with you, like how was your procedure, and then Darby. As Tyler kind of told me when we were prepping for this call, he wasn't used to you being the patient when he was used to being the patient. So can we talk about those two things?
Yeah.
Yep. So we started off with a consultation with our team at Shady Grove, and they gave us a set plan, what it was going to cost, and we went and said, let's do it. For me to start out, it was the sperm retrieval. So normally what they would do is they would put you out under general anesthesia, and they would take a small needle and take a sample from the epididymis. But because male CF patients lack the vas deferens, they couldn't get enough from the epididymis, so they had to take a biopsy of my testicle to get viable sperm that way, and it showed that I had normal, good, healthy sperm, just as in your words, you lack the wrong plumbing to get it out.
I think I said the bridge. There's no bridge from the testicle to the end of the penis. Yeah.
Well, so that's all Tyler had to do. I had the brunt of it. So for me to start out, it was a month-long process of medications, birth control, and so birth control was about 2 to 3 weeks to kind of shut the body down and kind of restart the your cycle. And once we concluded that, we went into our couple shots. So I had to do several shots into my stomach, and then a couple into a muscle later down the road. And that was not fun because it goes right into like the upper part of your butt. After those shots, that kind of produced multiple eggs at once. Normally a female produces 1 to 2, maybe 1, I believe, 1 to 2. And then with IVF, they make you kind of grow multiple at once to prepare you for an egg retrieval. And once I was prepared for the egg retrieval, they put you out under general anesthesia, and they go in and retrieve however many eggs are within a certain size. And I'm blanking on the size, but they have to be up to a certain size. They go in, they retrieve them. However many they get, they freeze them until they're ready to join the sperm together and try to create an embryo. After that, it's just a waiting period. We wait to see if any embryos are formed, how many are formed, and then our doctor called us.
And real quick, Darby, how long was that waiting period?
I believe that was about a month. Yeah, I think we were waiting about a month. And so I believe it was like within the first 5 to 6 days, that was when they would start showing signs of a viable embryo or not. And then we were waiting another 2 weeks before we had an embryo transfer if there was a viable embryo. Once we got to that point, that embryo transfer, it was, they had to use a catheter and sort of inject it up into your uterus, and place it near a wall. So it was a very specific spot that they were placing it, on one side or the other. And, I had to do that a couple times. But after that, it becomes a waiting game. You wait about 3-4 weeks after that, and they give you a call if it's positive or not. You go back in, you do a quick blood draw, and they test earlier than a normal like urine tests. They do your blood, and that's usually like a week or two earlier, I think. But that's it was a long, lengthy process on my end. Tyler got to sit back for most of it, but.
So tell me about that first positive pregnancy. Yes, it worked. Tell me about that.
So actually, we only had one. So we did 3 cycles of IVF, or I'm sorry, 2 cycles of IVF, and then 1 frozen cycle. So the first 2 cycles, the first cycle we had no embryos after we tried. There was nothing frozen. The second one, we had tried an embryo. It did not take. And then we had 1 still frozen, 2 still frozen.
We had 2 frozen from the second cycle.
Yes. So we did 1 and it did not take. We froze the other 2 and decided to try again. And that one came out to be positive. So that was the first positive. It took almost a year for the first positive. But that positive wound up being Peasley. So we still have 1 frozen embryo, but it was, I got the phone call. I came out of work and I was so anxious. So I had left work early because I knew I was getting the phone call. And, sometimes I was telling somebody at work, I said, sometimes girls just know. Women just know sometimes. And I was so anxious, and I got out and I got the voicemail from my nurse, and she said, "You have a positive, you need to call us, you need to come in." And I was like, oh my gosh, I don't know who to call first. Do I call Tyler? Do I call my parents? Like, I had no idea who to call. To
be clear, she didn't call me.
I didn't call him first. I really didn't. He was working.
I was about to say the right answer is to call Tyler.
Yeah, I had so many things running through my head, and we had so many letdowns before. So it was like this overwhelming feeling and excitement, and I think I burst into tears in my car. Like it was a good feeling. Yeah.
That's awesome. Thank you for sharing that. And that's very personal, so I really appreciate that. Now that you have been a parent for, 1 year and 4 months, something like that, right?
Yeah. Yes.
Right? Yeah. How is it for you both, and maybe Tyler, I'll start with you, living with CF, taking care of yourself as a transplant patient, right? How is it, and how is parenthood?
It's great. To start off, during our IVF cycles, I struggled with a little bit of depression. And part of my problem was I didn't talk to anyone about it. It very much, I was struggling internally with after transplant. I'd lost some very close friends with CF, and it was very hard for me to keep going of, well, why did they pass on? Why am I still here? Why did I get the second chance? And I struggled for a while to find my purpose. And when I got news that Darby was pregnant, that was my telltale sign of, this is your purpose. This is why you're here. This is why it took so long. This is why you've endured everything you've been through. It's given me a greater strive to work harder to keep my health in order. Something that I've never had to do before transplant was, everyone talks about, I have a 5-year plan, I have a 10-year plan. I had a 6-month to a year plan. I'm hoping I wake up tomorrow. And, now that I'm 4 years post-transplant, I'm starting to have that, well, this is where I want to be in 5 to 10 years. And I want to be there coaching soccer games or softball games. I want to be there for every experience and every moment with our daughter.
I was going to say, baseball is a huge part of your life, and I love that you just said softball. I love it. I play softball too. Darby, what do you think? How has it been with Tyler being a person with CF and a transplant and having a beautiful daughter?
Parenting's never easy, and to add CF and transplant on top of it, there's a lot of extra precautions you have to take. Like currently she's sick, so if I have to run out to the store and he's the only one left, it's a mask on for him, it's gloves on for him, it's, he tries to stay away from her. Sometimes we're trying to keep her in a completely different room from him. Being that she's a toddler, she's very much running the house. So if you try to trap her or keep her confined, it's a meltdown. And so it can be challenging some days just to keep Tyler healthy, to keep all of us healthy. But being with Tyler, being that he's had the transplant and he's immunocompromised, and it is a really big challenge because kids they are little germ factories, and so being that she's also getting ready to start daycare, we're trying to take precautions too, as far as keeping everything clean, wiping everything down, and I mean that's a normal thing in most households, but I feel like we kind of do it a little more often, and maybe a little OCD-ish at sometimes, but it really is, parenting is overall the same. It's just we take a little more precaution as far as health prevention and making sure Tyler is safe in doing it, in taking care of Paisley.
I love it, and it sounds perfect. And so I think I'll close with two questions.
Mm-hmm.
Number one, Tyler, what would you tell other males with CF about having biological children? Like, is there something you wish you would have known? And then the second question, which I'm happy to repeat, is how do you think our CF teams can best support people with CF who want to have children?
I think for advice would be don't give up that dream if it is something that you've wanted. From a young age, I said before, I wanted kids, but knowing what it came with in CF, and we weren't as advanced as we are now with Trikafta. Lifespans weren't extended when I was younger. So like I said, that was something I put out of my head because I don't want to get that hope. But like I said, don't give up that dream if it's something you want. Fight for it every day. Talk to people about it if it's something you want. And especially if you have family and friends and a spouse or girlfriend or whatever it is at the time that wants to have kids as well, have that talk early. See if you both have the same idea and goal, and have talks to find the financials to get it done. Because as much money as we spent, right now looking at it, the money doesn't matter. I can't even tell you what we paid, but all I know is I have a beautiful smiling daughter. And for support from CF Foundation or clinics, I think having these talks of is this something that you would be interested in? Not necessarily of, oh, well, if a patient comes to you to ask about it, bring it up, have those talks, and obviously when they're older, and just if there's something even the foundation or clinics might be able to help out with something with getting grants, or if there's research out there to help getting financial support for it, I think would be the biggest thing.
Darby, anything to add?
No, I think he hit it on the head. If we hadn't have talked to you in clinic that one day, I don't know where we would have started. It was a whole new journey for us. So to have you help and guide us, I'm gonna start crying. I'm sorry.
You're gonna make me start crying.
I don't know where we would have been. I don't know where we would have been without the CF clinic. So, thank you.
You're welcome. And after this, I'd like to share some pictures of you guys and Paisley, maybe one from your wedding day. I'll let
Absolutely.
you pick. But I just want to say thank you so much for sharing your story. I can already tell you that in 2 weeks, when I'm standing up in front of this podium, that people are going to be giving you a standing ovation because your story has been real and moving, and I very much appreciate it. So thank you so much. So wave at the camera. Thank you.
Thank you.
Take a picture. Yeah.
Okay, now you guys had me crying. Wow. Thank you so much. We will be, they've already seen their video, but we're going to be sending them that recorded session, so they'll be able to see that, and I just videoed that. Thank you all so much. Very much appreciated. They sent me probably 50 pictures to choose from. So I narrowed them down to 2 slides, but as they told you, they are high school sweethearts, so this was where he proposed to her. I believe it was actually at a CF fundraiser that his family had organized, and there's a few pictures from their wedding, which was about 6 months after transplant. And this is the day he walked out, or rode out in his wheelchair and then stood up and left, and that's myself, and then his surgeon, Dr. Bush. And then, I love the onesie. I can't read it really well. The greatest, because it's green. Basically giving the honor of his donor. He would never have been here without her. He did want to include a picture of her, but I didn't have permission to use that. But anyway, so then this is Paisley throughout her life, and Tyler played baseball throughout his life, so this is him at an Orioles game. So we thank you, Tyler, Darby, and Paisley.
So you're going to hear a lot of great data coming up over the next hour or so, but we really thought it was important for people to remember that all of this great data represents individuals all across the country, all across the world, who are really talking to us on a daily basis, it feels like to me in clinic, and probably to you too, Natalie, about pregnancy and parenthood. And so it's something that's really on the onus of us to know the data to try to help them make up their individual decisions. Before I get the first speaker up here, I wanted to make one note, and that is that the conference organizers have asked that we change the format a little bit this year, and maybe you've noticed it already at the symposia, where the speakers will come up and give their talks, but we won't be answering any questions until the end, and so they'll all come up at the end. In the meantime, you guys can use the app, so just go to the session and put your Q&A there. We will cheat a little bit and use one of these mics for those of you who are brave and want to actually ask your question in person, but we will ask you to come up front, and we'll have the mic down there so that the people who are online later watching this will be able to hear what the question was. So without further ado, I will invite up our first speaker, who many of you know. Dr. Tracy Kazmersky is an assistant professor at the University of Pittsburgh School of Medicine in the Department of Pediatrics and the Division of Adolescent and Young Adult Medicine. She's a pediatric pulmonologist and health services researcher at UPMC. Her research really centers on the improvement of comprehensive care for adolescents and young adults with pediatric onset chronic disease, and she is also one of the original members of the formerly Women's Health Research Working Group, now Sexual Health, Reproductive, and Gender Working Group, and she is now officially actually the vice chair as of July. So welcome, Tracy.
Thanks, everybody. So I'm going to be talking today on parenting with CF. I couldn't have wished for a better intro than that. I am still kind of crying, so that's okay. I'm sure I'm not the only one. These are my, let me see if I could advance slides. These are my disclosures. And this is a slide that I think we're all well aware of. This is a prediction from 2018 about the number of adults in the US with CF as we project through time. And as you can see here, the prediction is within the next 15 to 20 years, this population is going to nearly double. So when we think about this, why does this matter for sexual and reproductive health? And I think prior research, even prior to the era of widespread highly effective modulators, really showed that 4 out of 5 young people with CF intend to have future children. So these are their intentions. What is the reality showing us? Historically, pregnancy was really not considered prudent for people with CF until the early 1980s. But you can see from the graph at the bottom that spans from 1990 to 2019 that those numbers are climbing. We all know what happened in October of 2019 here in the US, and this is borne out in the data, where the number of pregnancies among people with CF jumped to 619. And we thought, well, maybe that's a blip. This went up to 675 in 2021. I'm not going to talk a lot more about pregnancy because Dr. Jane's going to be up here next and sharing more. But I will say that we knew what this looked like before modulators. And there's a huge, wonderful study that's ongoing that many of your centers are participating in that's looking at it in the modern era. But pregnancy is not the only way to build a family. As you can see here, people with CF have the ability to have children through pregnancy, adoption, step-parenthood, foster care, or surrogacy. When we think about pregnancy, as Tyler and Darby highlighted, it's really sometimes not that straightforward. So we know that because of bilateral absence of the vas deferens, 98% of males with CF are infertile and require assisted reproductive technology to have biologic children. In females, the female anatomy is usually normal, but CFTR in the female reproductive tract may lead to thickened cervical mucus and pH that does not well support sperm capacitation and may impair sperm fertilization or egg fertilization. So they also may experience some subfertility and require ART. Tyler talked about this too. When we think about ART and CF for males, that first step is often sperm retrieval. And this occurs either via an open surgical approach or through the skin using a needle. This is either from the epididymis or from the testes. After that sperm is retrieved, it's combined with an egg and can be implanted using in vitro fertilization. And this seems very simple. You do all these things and you become a parent. But each of these paths is not linear and is not super easy for anyone. But when you think about somebody with CF, it's even more complicated. People with CF think about parenting and pregnancy's impact on their health, the impact of CF on their family and their potential children, on their relationship with their partner. Do they need assisted reproductive technology? And what is the cost and availability of these different options? What is the support of their family in these decisions and the support of their CF team? And what is the impact of CFTR modulators? So that's a lot of questions. And we decided in recent research to start humbly and to start with questions of people with CF who experienced parenthood. So these are the 2 questions that we were interested in. What do parents with CF want and need? And what is it like to be a parent with CF now in the age of widespread use of highly effective modulators? So for this first question, what do parents with CF want and need? We recruited people with CF with at least 1 child less than age 10 to participate in an individual interview exploring their process of deciding to be a parent, adjusting to parenthood in the context of their CF, and the interplay and impact of CF on parenting and the impact of parenting on CF care and adherence. We interviewed 37 parents, and these were via a variety of family building paths. I don't have time to go through detailed methods and results today, but I will encourage you to visit poster 311, where you can not only see the key themes from these interviews, which I'm about to share with you, but importantly, you're going to hear and, see the words of the participants, which really do this much more justice. So there were 5 key themes from these interviews. The first is that parents with CF need to prioritize their care routine while balancing their role as a parent. The second theme that emerged was that delegating specific tasks or roles to partners or extended family can help alleviate conflicts between parenting and CF. And this was especially important around times of sickness or hospitalization. Third, people with CF desire support and resources specific to parenting from their CF care team. Fourth, and this is something that Tyler and Darby really highlighted in their video, while it is logistically and emotionally difficult to avoid illnesses transmitted from children, risk of infections can be mitigated by taking precautions. Many of the people we interviewed went into great detail about what precautions and what was their, quote, sick plan, not when they were sick, but when their children were. And then finally, parents with CF desire clinic-facilitated connections with other parents with CF to share strategies, experiences, and to provide emotional support. So what is it like to be a parent with CF now? We wanted to look at this not through a traditional interview qualitative methodology, so we chose a methodology called Photo Voice. Photo Voice is a community-based participatory research method that was developed in the 1990s. It has 3 goals. The first is to enable the participants to record and reflect on their strengths and concerns around a topic, in this case, parenthood with CF. The second is to promote critical dialogue and knowledge about these concerns through large and small group discussion of the photographs that are taken in the study. And then finally, third is to reach policymakers and other change agents with the results to affect change or growth. We're the policymakers and change agents in this case. So we recruited people with CF with at least 1 child less than age 10. We used a wonderful partnership with the CF Foundation Community Voice team and local recruitment at 2 CF centers. So what people do in the study is participants decide as a group what research questions they want to explore. During a series of meetings, they present the photographs that they individually have taken and explore how they relate to the chosen research questions. And then as a group at the final meeting, they analyze the photographs to identify their themes and select representative ones and write captions. This is detailed in poster 310, and simultaneous to this, Olivia Stransky, who's the lead study author, is presenting this in room 121C. These are the main 3 themes that I'm gonna highlight for you. I don't have time to read all these captions, but I'm gonna choose one from each. Really, the first major theme that came out was that it is important for parents with CF to pay attention to the joyful aspects of parenting and to cultivate positive experiences. I'm gonna read from the center photograph. This is what the caption reads. As a parent with a chronic illness, I've come to really appreciate the magic in the little moments of life. I've learned to cherish things that are overlooked as being ordinary and mundane by most people, because I know what it feels like to live without them. When I'm sick, I don't miss the big moments as much as I miss all of these little moments. My little girls teach me every day how to see the beauty amidst struggle. The second theme was around balance. Parenting with CF requires balancing your own needs with those of your child, and creativity and flexibility can be key. I'm gonna outline what's going on in the first picture, and I will highlight that this was not the only picture that looked like this that was submitted by a participant. In this picture, this woman is on an online work meeting. She is exercising. She has her vest on, and she is doing a nebulizer treatment. In the background, she has a toddler being a toddler. She has a school-age child on online school, which she is overseeing. Right? Right. The caption reads this: balancing daily care with kids around requires creativity, multitasking, and inspiration from other parents and people with CF. It is a fantastic feeling when my spouse or care team recognize the mental and physical hurdles we jump through to enjoy our kids and be healthy every day. The final theme that came out was around uncertainty. Parenting with CF consists of competing priorities and expectations, often with no clear, correct choice. The first caption reads, experiencing joy and euphoria after a long IVF process, feeling happy it worked, but worried about what's to come from a late fatherhood at the age of 41. So these are a snapshot of the photos our participants shared and the captions that they wrote. The full photo voice gallery is on display at Arch Street 108. I encourage you to go there after this and read the words that our patients and families are sharing with us. I'm going to share one more. So this is a picture at a crossroads. The caption reads, the decision to become a parent and parenting is filled with tough choices. You must make long-term decisions with an uncertain future while only being able to look down a small part of the road ahead. I'm going to share another story about the road ahead. So this is Molly. She is one of my colleagues and co-investigators on many projects. She also is a 34-year-old woman with CF. And many, many years ago, when we were working on a project, she said, what would be helpful is something to help me decide if and when I should be a parent. And I said, what does that look like? What does that mean? And she said, let me send you something. So she sent me a Word document. This is titled Molly's List of Considerations for Whether to Have a Child. Molly is also type A, like myself. We get along very well. So there are many pages to this that I'm not showing you. And many of those were talked about by Tyler and Darby, the financial considerations, the support, etc. But this part of the list is dominated by her CF. The first one is my favorite. Kids are germy. And I think that there's lots of things here. How CF and pregnancy are going to interplay, how it's going to affect her disease, what medications are safe or unsafe. How is she going to balance her chronic disease with the demands of being a parent? What would happen to her spouse and her children if she got sick? What would happen if she died? And the thing that bothers me about this list is that I don't have answers. I don't know what are the health repercussions when somebody with CF becomes a parent, but I do know that kids are germy. So we decided to try to answer this. So using data from the United Kingdom CF registry from 2015 to 2019, we looked at 296 parents. The beauty of the UK registry since 2015 is that they collect data on pregnancy not just in people with CF, but also in people's partners with CF. So this is representative of mothers and fathers. We evaluated the impact of having a child on health in the first year before becoming a parent to the first year following parenthood. And in brief, this is what we found. We found a significant decrease in percent predicted FEV1, as well as body mass index, and a significant increase in pulmonary exacerbations. We also found that CFTR modulator use mitigated parenthood impacts on percent predicted FEV1, but not on BMI and pulmonary exacerbations. When you do a registry study, it's always imperfect because you don't have all the data that you would like to have when you're looking at something. And this is no exception. The study was not done in the era of widespread, highly effective modulator use. It only included pregnancy, so it did not include those other aspects or other paths to parenthood. And it really focused on CF health outcomes, BMI, pulmonary exacerbations, FEV1, and short-term outcomes. It did not look long-term past that first year. It did not look at mental health. And these are really key things that we should be considering as we take a comprehensive look at parents with CF. But as Banksy said, there is always hope. And indeed, there is a study that is going to start in spring of 2023 called HOPE CF, or Health Outcomes of Parents with CF. Its primary objective is to determine the health impact of parenthood on people with CF in the era of CFTR modulators. There's 2 parts to this study. The first is a 10-year retrospective registry cohort study at 8 US CF centers. We're going to pair registry data with a brief parenthood survey and look at 249 parents with CF and compare them to 747 non-parents. This will allow us to determine the effect of parenthood on pulmonary health and the impact of all the CFTR modulators that have been developed and are used within the US population. The more exciting aim, I think, is aim 2, because it's going to allow us to do a prospective cohort study at 18 US CF centers of new parents with CF. We're going to be able to follow people 5 years after they become a parent to evaluate the comprehensive health outcomes and really identify modifiable factors influencing the impacts of parenthood. The hope is that we can understand, as people are going through it, what the impact is, not just on their FEV1, but on depression, anxiety, what the role is of parental stress, and what responsibilities you have as a parent. Our hope is to identify what are things that we can change, and what are the critical time periods where the interventions will matter most for our patients and families. So that's very exciting. More coming soon, stay tuned. And that feels really good, except we have people with CF who are parents or who are considering parenthood right now. So I encourage us as providers to develop the space to talk about these, quote, messy, hard things. We need to do so in a way that respects people's reproductive goals. And this is often easy when the person in front of you has an FEV1 in the 90s and a wonderful support system. But we should do this regardless of how sick someone is. We must partner with patients and families in open conversations about their family building and their comprehensive reproductive health throughout the lifespan. I don't like to leave talks with people feeling like they don't have resources to do a good job when they leave NACFC. So do the best you can until you know better, and then when you know better, do better. So the data is going to be generated and the research is coming. But there are wonderful resources available now. There's an NACFC 360 session on supporting adults with CF to raise healthy families. It is for the multidisciplinary CF care team. It is wonderful. There's also wonderful PDF resources for people with CF on parenting as an adult with CF. And the last thing I'll encourage everybody to consider is a way to open this conversation with our patients. I'm a pediatric pulmonologist. I've started at age 13 or 14 with all of my patients to ask this question: do you ever want to become a parent? This opens a path to talk about their knowledge of reproductive health in CF, and it also opens a path really to understand what their hopes and dreams are, and creates that space for them to re-broach the subject when they're ready and in their own time. This quote is long, and I am going to read the whole thing. This is one other picture and caption from the Photo Voice Project. I didn't know that I was ever going to be able to have a kid. Obviously, growing up with CF, being told that you're not going to live to adulthood, being told you're not going to get to have all these experiences that you dream of, it makes you so much more grateful and appreciative for these moments. I think it was a combination of the contrast between this making me so happy and then just being so grateful to be able to have a child and to be able to still be here today when the doctor said there was no way I would be. That's what's going on behind the picture. But I think it's so easy to get caught up in the day-to-day grind and sweating the small stuff. I really try to just stay present and just be grateful. Even in those moments where I'm having a rough time with my health or other things are going on, I just feel so, so grateful to have this little miracle angel baby who is so sweet and who makes every day so much better. Everyone's choice is different, but my experience has been that it's been the greatest joy of my life being able to be a mom. And I know my son's still young. He's almost 20 months. But just these last couple years with him have been the greatest joy of my life. While they've been challenging, have been the most rewarding and wonderful. On the topic of choice, for the safety of the presenters and attendees, I urge the Cystic Fibrosis Foundation to commit to ensuring that future meetings are held in locations where elected leaders understand the importance of reproductive freedom, gender-affirming care, and the sanctity of the physician-patient relationship. I wouldn't be able to do anything without the support of the people on this slide and many, many more. The Cystic Fibrosis Foundation has supported this research and supported me. And I would never be able to do anything without Olivia Stransky, who is my research coordinator and friend. Most importantly, all our patient partners and participants are why we're all really here. So thank you so much.
Thank you so much, Tracy, for that really great talk. I'm going to introduce now our next speaker, Dr. Raksha Jain. Dr. Jain received her MD from the University of Texas Houston Health Science Center, completed residency at UT Southwestern, and her pulmonary and critical care fellowship there as well. She is currently participating in and leading several multi-center trials related to the CF therapeutics and development. And she is also moved from being the vice chair of the sharing group to the chair of the sharing group. Welcome, Dr. Jain.
Thank you. Thank you all for coming today. I'm going to focus my talk today on pregnancies, and there is a session tomorrow where we're going to be talking about men's fertility. That's in the session called What We Don't Talk About, if any of you guys are interested in hearing more about that topic as well. What am I doing wrong? Okay, these are my disclosures, none of which are related to the content of the presentation today. Okay, I think as we've heard from many today and throughout this meeting, that we're thrilled that the median predicted survival age for people with CF is now greater than 50. With this, many are considering parenthood, as we've heard, and there has been a huge increase in pregnancies. This is a graph taken from the CF Foundation registry data going up to 2020, where you can see in 2020 there was a more than doubling of pregnancies relative to the 5 years prior. With this, if you look at the trend of the timing of this, you can see on this graphic on the right that really this jump correlated with the timing of the release of ETI here in the United States. And what exactly ETI is doing from a fertility standpoint, we still have much to learn, but this correlation at least makes a suggestion that fertility is likely improved. You can see also in this picture down here at the bottom left, this is a patient at my own center that Dr. Taylor Kauser and I published in the Journal of Personalized Medicine last year, where this patient underwent a hysteroscopy when she was trying to get pregnant. Shortly thereafter, she was started on ivacaftor, and you could see her pre-uterine picture from her hysteroscopy and her post-ivacaftor picture, and there was a huge amount of mucus and thick bands noted pre-starting that highly effective modulator with a near clearing post her highly effective modulator. She also subsequently got pregnant within several months of starting ivacaftor. So again, I think we don't know the full details of the science behind this. Tracy highlighted some of this in her talk, but we have much to learn, and I think the suggestion is at least there that there is likely a possibility that highly effective modulators are improving fertility in women with CF. Okay. All right, so I think with this comes a number of questions about outcomes of pregnancy on people with CF, which is really the focus of this. And I'll tell you, we still have much to learn, but I broke this into a few different questions. So first of these is, what is the outcome of pregnant people with CF versus pregnant people without CF? And I've chosen just a select few publications here, but you can see one that was published back in 2017 using a California database from 2005 to 2008. They found that in California, 77 mothers in this database with CF were compared with over 2 million mothers without CF. They did find in this CF population that the mothers were more likely to have gestational diabetes and higher rates of C-section. They also found that the neonates of these mothers with CF were more likely to have preterm deliveries, meaning less than 37 weeks, and have congenital anomalies. Looking at another publication on this topic that was used the nationwide inpatient sample between 2000 and 2010, this included over 1,000 mothers with CF and compared them with 12 million mothers without CF. They again in this study found that these mothers with CF were at increased risk for death, pneumonia, preterm labor, and gestational diabetes. And I think some of these data are what have set off alarm in a number of clinicians that take care of people considering pregnancy with CF. So just to summarize this, I think what you want to also know is these data were prior to highly effective modulator therapies, but looking at these cohort studies, there was increased complications noted in pregnant people with CF relative to people without CF. Then looking at the next question of what are the long-term outcomes of pregnant women with CF versus non-pregnant women with CF. And again, I chose a select few publications here, but one of the most widely quoted of these is an analysis done by Goss and colleagues using the CF Foundation registry from data back in 1985 to 1997, and they did a survival analysis looking at whether there's a survival difference in those who became pregnant versus those who did not become pregnant using the registry. There was about 680 women at this time in the registry who'd become pregnant, and when they did their comparison, there was no survival disadvantage in those who became pregnant. In another study done by Schechter and colleagues, they used the epidemiologic study of CF data between 1994 and 2005. Here they compared 119 women who became pregnant to those who did not become pregnant and found that, again, that there was no increase in mortality, but they did find that women who became pregnant had more illness-related visits, more pulmonary exacerbations, and reported lower quality of life scores. But again, it's important to highlight these were data prior to the wide availability of modulator therapies, but it is important to know that there was no long-term adverse outcomes of becoming pregnant versus those who chose not to become pregnant with CF. So what about short-term outcomes? So in a nice study published by a group from Israel, and I think I see the author in the audience, I think, but so this was a relatively recent study, and it was done at multiple centers, so over 10, I think approximately 10 centers from internationally, and it was a retrospective cohort study between 1986 and 2018. So using much newer data, but still prior to the wide-scale use of highly effective modulator therapies. In this study, they looked at 171 pregnancies in 128 people with CF between the ages of 18 and 45. They broke up their time periods of 1 year prior to pregnancy versus during pregnancy versus post-pregnancy, and looked at this in a few different ways. So I'm not sure how well this is transmitting, particularly in the back of the room, but the top left graph is broken down by disease severity, where they define those with mild disease as those with an FEV1% predicted greater than 60% and a BMI of greater than 21, and those with moderate to severe disease having an FEV1 of less than 60% and a BMI of less than 20. When they looked at that FEV1, again, short-term, pre, during, and post-pregnancy, while it looks like there's a bit of a decline, there was no significant decline in FEV1 amongst those two groups. Granted, the one with the moderate severe disease started out lower, but not with a significant decline. When you look at the top right graphic, these are broken down into people who had Pseudomonas colonization with the dark black and those without Pseudomonas colonization. Those with Pseudomonas colonization in the gray and those without in the black. And you can see those with Pseudomonas colonization did have a greater decline in their FEV1 relative to those who did not. And finally, in that bottom graphic, this is broken down into people with pancreatic insufficiency versus those who are pancreatic sufficient, with that light gray being the pancreatic insufficient ones and the black being the pancreatic sufficient ones. And here again, you can see that those with pancreatic insufficiency did have a decline in their lung function post-pregnancy relative to pre. So it's important to note that there are some risk factors that you have to think about when you're counseling your patients on what could result in a decline in lung function. But importantly, at this point, despite the fact that it's more modern data, again, there was not wide-scale use of highly effective modulator therapies in these data either. In another study that was relatively recent and very nicely done, and I wanted to highlight, is that this is looking at maternal lung function in association with infant delivery outcomes in particular. This was a study based in UK, and they looked at data between 2015 and 2017. In 71 pregnancies, they found the mean gestational age at delivery overall was 36 weeks, so a little preterm. They found the mean birth weight for gestational age was in the 61st percentile. And when you look at some of the data here, I think it's important to note that they did find a positive correlation between lung function, which is on the x-axis of both of these graphs, versus in the top graph, the completed weeks of pregnancy, or in other words, gestational age, and the bottom graph birth percentile. So what that's really telling us is there's a positive correlation between maternal baseline FEV1 and mean gestational age at delivery, as well as mean birth weight percentile for gestational age. So that lung function, I think we still have a lot to learn, but it's at least giving us a sense that baseline lung function does matter. But I will say that we don't know what that baseline lung function is. I think people always want to know, and I know for those of you who are in clinic, you probably get this question from your patients often, where they say, what lung function is okay for me to get pregnant? And the answer, unfortunately, is we don't know. The historic answer, really more by opinion, had been 50%. But we don't have hard, fast data to know that. And we particularly don't have data post highly effective modulator therapy to know that answer right now. So I'd be remiss if I didn't at least mention pregnancy post lung transplant. I think this is a much more challenging question, and one we also don't have a lot of data about. But the little data we do know suggests that there are very high complications, both maternal and fetal complications, when dealing with a person who chooses to get pregnant after a lung transplant. So in a couple of small studies, one of these used a national transplant pregnancy registry database and included 30 pregnancies. Only 12 of those were in women with CF, but they actually found that 60% experienced preterm birth, 11 had infant complications, there was a high number of low birth weight infants, and unfortunately 2 neonatal deaths. They also found a high rate of lung transplant rejection, up to 25% in these women, and the medications in this scenario are really not well understood, but I do want to at least point out a couple of medications that many of you may be familiar with. One of these categories is mTOR inhibitors that are often used as an immunosuppressant, sirolimus being the classic one, and anti-proliferative agents, with the classic one being mycophenolate mofetil. Now, these therapies are known to have a pretty significant impact on the fetus and can be teratogenic. So you really have to, again, counsel patients, and I know some of you practice transplant medicine, some of you work with colleagues in transplant medicine, and every center will be different. But some suggest overall you want to either avoid pregnancy altogether post-lung transplant, or at least consider potentially waiting 2 years after transplant so that the person can achieve the lowest possible doses of immunosuppression before getting transplant. But this is a very big conversation you have to have with the transplant team, the patient, everybody involved, because this is not insignificant. And some centers would suggest that they don't advise this at all. So it's going to be very variable across places that you go. So I think Tracy very nicely pointed out that the key to all of this is to understand that while we have some data, really we're still at a point where the key is to have discussions with your patients, that there are risks and benefits that you have to factor in. And this is particularly true now in the post-modulator era, where people are feeling better and better. We know over 20,000 people, at least here in the United States, are on CFTR modulator therapy. They're leading healthier lives. They want to have children. We're thrilled by that, but they also want us to answer their questions about what's the impact on their health, what's the impact on baby. So you really have to balance these. And when you look at maternal risks and benefits, while we know there's huge benefits to being on modulators, there are also some risks to stopping modulator therapy. This has been pointed out in sessions prior, and I think it's important to recognize there has been reports of destabilization in health when people come off their modulators, and you have to let people know this because we have to factor in mom's health and the potential new infant's health as well. You also have to factor in infant risk. And I know these people who are thinking about having their children really want to know that question as well. And it's a hard one to know. We probably have even less data in that regard. And Dr. Fortner is going to go into some of that data as well. But we do know that modulators pass through the placenta and into breast milk. So infants are exposed to modulators in utero and if they are breastfed by a mother who is on a modulator therapy while breastfeeding. And we know that there can be an impact on the fetus and the newborn. Much of this is unknown, but we're slowly learning a little bit more. So what do we know? There's been really 2 publications out there to date, not a lot, that at least gave us a sense of some information about this. The first was an international survey by Nash and colleagues, and I know Dr. Taylor Kauser was involved in this study, that surveyed providers internationally on pregnancies that they had followed at their center where people had continued on modulator therapy. So in this, 44 of 66 pregnancies had people who continued modulator therapies. And at this time, it was largely ivacaftor, lumacaftor, ivacaftor, and Tez-Iva. In these, there was reports of 2 maternal complications, and these were provider-based deemed complications that they thought there was 2 maternal complications that could be related to modulator therapy. One of those included a pulmonary exacerbation and one acute AML, or acute myelocytic leukemia. And again, this was provider deemed that it could be related. But importantly, there was 9 women who stopped their modulator therapy and had a decline in their health that was noted by these providers. And finally, there was no modulator-associated infant complications noted here. In another study that was done, led by Dr. Taylor Kauser, looking at post-ETI, a very similar survey of providers and what they experienced when their patients started ETI and took it during pregnancy. This had included 45 people who chose to continue ETI during their pregnancies. Here, there was 1 maternal complication that was deemed related to ETI. In this case, the mother experienced cholecystitis. 2 were complications were deemed unknown in relatedness to ETI, again, a cholestasis patient and a pulmonary exacerbation. And 3 were the infants had complications that were deemed unknown in relatedness to ETI, including transient transaminitis and congenital malformations. So overall, you could at least see that these numbers are not high. These are small populations, and we recognize, but at least it gives us a signal that we should not be in a panic state and can provide whatever data we can related to this to our patients as we learn more. So I will tell you, just recently, and last year at NACFC, a group of us has started to look at this question. And in this study that's funded by the CF Foundation, this is a retrospective evaluation that's been done at 11 adult US centers, collecting data on pregnancies directly from the EMR to try to understand the impact of modulators on maternal outcomes. And I know many of the centers here in the audience are helped with this data collection. And in this data collection included data from 2010 to 2021. It was a longitudinal data analysis that used mixed effect models to look at the effect of pregnancy on FEV1, BMI, and pulmonary exacerbations. Here we adjusted for a number of confounding effects, including age at conception, race, pre-pregnancy baseline FEV1, diabetes, whether the pregnancy was planned or unplanned. And this was one of the major advantages of using the EMR, is we actually had these kinds of data from the centers directly. And when you look at that data, we had 228 pregnancies reported in 180 people. And overall, you can see that the group, about a little over 150, used no modulators during their pregnancy. 22 were on non-highly effective modulator therapies, so typically Lumivir or Tez-Iva, and 55 were on highly effective modulator therapies. This is just some of their baseline characteristics, but to get to the data itself, you can see that what we found on the left-hand side is their adjusted mean FEV1. So we adjusted it for all the variables that I mentioned earlier, and you can look at the mean difference on no modulator therapy. There was a decline in FEV1 of minus 2.4%, and the non-highly effective modulator therapy, fairly similar but non-significant at minus 2%. And in the highly effective therapy group, there was an increase in FEV1 of 2%. So when you look at the interaction effect of these 3 groups, it was highly significant. So this at least is a suggestion that maternal health stabilizes in the setting of highly effective modulator use when it comes to percent predicted FEV1. When you look at pulmonary exacerbations in the middle and BMI on the right-hand side, there was no significant difference in the pulmonary exacerbations pre and post pregnancy, and those who used highly effective modulators versus those who were on non-highly effective modulators or none. And then you look over on the right-hand side at BMI, and there was a significant improvement in BMI in those who are on highly effective modulator therapies when it comes to the interaction effect between the other two groups. So pretty encouraging overall relative to what we've seen, but still leaves us with a lot of unanswered questions. And again, we don't know what to counsel our patients on that FEV1 of where's the right place and where's not the right place, and hopefully some of this data will slowly come over time. So one last analysis from this last data set that I did want to share with you, we also took a look at planned versus unplanned pregnancies in CF. And this is really a study that's never been done to my knowledge because it's a very difficult set of data to capture. But again, with the help of these 11 centers, we're able to get pretty granular data about this. And we're looked at 226 pregnancies here, where we found that 90 of those were unplanned and 136 were planned. And when you look at the impact of pregnancy or pre-pregnancy versus post-pregnancy in the planned in the black lines here and the unplanned in the gray groups, you can see what really stands out is the left-hand side, which is pulmonary exacerbations. And there was a greater number of pulmonary exacerbations post-pregnancy and those with unplanned pregnancies relative to planned. The others did not come out as significant. I should also point out in the middle graph, though, in both groups, there was a decline overall in lung function, which has been similar to what has been seen in the data previously. So finally, I just want to end on, Tracy touched on this a little bit, but I think we're really excited to try to answer some of these questions that we all have about pregnancy out there. And the CF Foundation and TDN are supporting a study called the Mayflower Study, Maternal and Fetal Outcomes in the Era of Modulators. My colleague, Dr. Jennifer Taylor-Kauser, and I are privileged to serve as PIs of that study, as well as Melissa Putnam, who is leading the evaluation of diabetes by using continuous glucose monitoring. And what this study is really setting out to do is to determine the effect of pregnancy on maternal health, including FEV1, exacerbations, BMI, glucose control, mental health, as we're going to have mental health questionnaires throughout, and a number of other maternal variables, as well as infant outcomes. And I think that's been something that when we all look through the charts, we really struggle with because we don't have a lot of that data. We try to gather what we can, but we don't. And this study, importantly, as you can see in that blue on the right-hand side, we're going to follow these infants up to 2 years after delivery, so we can really capture some information about their developmental milestones and a number of other factors. There's also 2 key sub-studies in this Mayflower study. One is looking at the pharmacokinetics of modulators in the mothers and in the infants, and is going to collect that at a subset of sites, as well as looking at continuous glucose monitoring in these mothers throughout pregnancy to really understand diabetes at a much higher level. And we're excited to report that we actually already have 100 enrollees in this study. We're aiming for close to 300, and we really appreciate all the sites. There's about 40 sites participating in this study. So with that, I'll just summarize that we've really entered this new era of CFTR modulators. It's likely that we're seeing improved fertility in females, and we really have to spend time counseling our patients on this information so that we can, one, ideally plan pregnancies and have the opportunity to have these conversations, and 2, really understand more about the long-term impacts of pregnancy on maternal health overall. We do know a few things, and that is low lung function, pancreatic insufficiency, poorly controlled diabetes, and Pseudomonas aeruginosa are potentially associated with worse outcomes, at least in a pre-modulator era. We don't know yet much about that in the post-modulator era. There's risks and benefits that we have to counsel our patients on about these modulators in infants in particular, but I think the Mayflower study will really help answer some of these questions. So I do want to thank, I know Dr. Taylor-Kauser mentioned our sharing working group, which you'll see a number of these people in the session today, which have really spearheaded a lot of these topics and more to come on men and women's health and people of all gender identities, we hope in the future. And I have a few people I want to thank, including my co-PI in a number of these studies, Dr. Taylor-Kauser, Ashley Keller, who We've worked together for almost 12 years and helped create the database for many of the study that I pointed out on modulators. Min-Jae Lee, who has done the statistics on many of the studies you've seen, including the parenting study that Tracy shared, all the participating sites in a number of these studies, as well as the team leading the Mayflower study. And I, too, just want to mention the important message of the fact that we urge the CF Foundation to commit to ensuring that future meetings are held in locations where leaders understand the importance of reproductive freedom, gender-affirming care, and the sanctity of the physician-patient relationship. So thank you for your time.
Thank you very much, Dr. Jane. So our last speaker that we will have come up before we invite everyone back up to answer questions is Dr. Chris Fortner, who I've known for a really long time. I probably won't say the date, but we've known each other since fellowship. So he's an associate professor of pediatric pulmonology at SUNY Upstate in Syracuse. He's the CF Care Center director, the TDN site director, and the pediatric CF program director. And he is going to talk to us about his experience of taking care of a child who was exposed to modulators during his mother's pregnancy.
Okay, thank you to the organizers for inviting me to share this story. It's challenging to follow such great speakers with great data and knowing about all the studies that are happening and that are starting. You know, this is not a study, this is a story. This is one patient's story, but it's a pretty good one so far. So I have no relationships to disclose for this presentation, but I must warn you, there's a discussion of off-label use of medications. In pediatrics, we're kind of comfortable with this idea, but if you're not, plug your ears. So this is the second patient at our center that I have the privilege of taking care of who has cystic fibrosis, but was born to a mom who also has cystic fibrosis and remained on modulator therapy throughout her pregnancy. So this is a little different than the case report that we published last year and that we shared at the virtual physician grand rounds last year. But some similarities: mom's got CF, dad's a known carrier. Mom decided for her own health to stay on her modulator. The pregnancy itself wasn't complicated. And much like the first case, the child's pancreas was okay enough to fool our state's newborn screening, at least first pass algorithm, because his IRT wasn't elevated. But thanks to our center coordinator and the coordination with the adult side of our center, we make sure to let the state know about these so that they can run genetics for us when we ask. And so even though his official first screening was negative, the genetics showed that he has Delta F508 and an E92X mutation. So this being our second at-bat, it's not the second at-bat around the country. There have been other cases and stories that have helped contribute to us doing a better job this time. Not that we think we did a bad job before, but we are trying to get better with each one of these stories as we learn from each other. And you know, we learned from our first case, we learned from Dr. Trimble's work with the breast milk concentrations of ETI, and we learned from Dr. St. Peter's case of treating a mom on purpose to transmit the modulator to the developing fetus. And we learned some from their stories after they were born as well. So now we start to talk about where we are different than the first case. He's not homozygous, meaning he's got to wait until he's 6 or maybe 2 if he's lucky, but there's not going to be an approved modulator for him anytime soon. And mom was unable to breastfeed in this case. Our first one breastfed for a good long time, but for this patient, different mom, different baby, the breast milk never came in. But that led us to some concerns after conversations with Dr. Leisinger that he's going to share tomorrow morning, and also from results from the G551D ferret model that abruptly withdrawing modulators, just like it's bad for lung function in older patients with CF, abruptly withdrawing modulators seems to be bad for either newborn ferrets or newborn people that were exposed and had modulator around for their entire gestation. Abruptly withdrawing it has led to significant pancreatitis. And this is a boy, so maybe there's other organs we can learn about. So for baseline evaluations, for both of these, we check for possible harm by sending them to ophthalmology. Our team there is fantastic about getting them in as early as we ask and doing liver function testing as early as we know. We also confirm that they have CF through sweat testing, in addition to the genetics that our state was able to gather for us. And then we check for possible benefit. What's his fecal elastase look like? And does he have a vas deferens? And how do you even test when they're this little? And the answer to that, I've talked to many radiologists at various centers. They're like, you might be able to see it by ultrasound, but if you don't, that doesn't mean it's not there. So short of an MRI, there wasn't a great imaging strategy to know. So we talked to our urology colleagues to see if they could help. So his ophthalmology exam in looking for harm, no obvious harm. Had a normal exam, no cataracts, no other concerns. His liver function testing at 4 weeks old, also no signs of harm. Normal liver function. I don't know what his bilirubin was at birth, but he didn't have any reported jaundice, so bilirubin was also normal. His sweat chloride was normal. No, it wasn't. It was consistent with cystic fibrosis. So it was 62, which with the 2 mutations he has, feels a little low to me, but we'll talk about that in a bit. His fecal elastase on the first sample we got was normal. And when we sent him to urology, they got him in by the time he was 8 weeks old, and he had 1 palpable vas. So I'm starting to rethink everything I thought I knew about CF. And I went back to this article by Steve Rowe and Franca Corso and JP Clancy. I was like, wow, 3 rock stars, 1 paper. But what I like about it is not the rock stars who put it together, but the y-axis having the sweat chloride and the x-axis having the percent of CFTR function. And the curve there is some of the clinical manifestations of CF. You know, the ones with the least CFTR function are pancreatic insufficient and tend to have the higher sweat chlorides. The ones who have a little bit of CFTR activity, they could be pancreatic sufficient. And then the ones with the, fingers crossed this laser pointer works. So, you know, the ones who have a decent amount, you know, 10, maybe even 20% of CFTR function still can have congenital absence of the bilateral vas. So if that's not the first figure you think of when you come to a case like this, that's okay. I actually was remembering the triangle figure that, you know, has, as you go down the triangle, fewer and fewer clinical manifestations of CF as the molecular phenotype or the impact of the mutation has less and less impact on CFTR function. But if you look at the bottom of that triangle, we've got normal female at the bottom. What we don't have on that figure is normal male. So we might be here. So now we've got this newborn boy with at least 1 vas deferens, but you know, should we treat him or not treat him? There are unknowns to treating him. You know, first and probably biggest is how to get the medication. It's not like there's an infant form available or it's anywhere close to approval or any of that. What would the dosage even be? What would the safety margin even be? Do infants metabolize this differently? There's a whole lot of unknowns. And so should we wait until something, you know, should we wait for something bad like pancreas problems, or should we wait for something good like approval for younger ages? But there are unknowns to waiting as well. Will he withdraw? Will his pancreas fail? And if so, when? will his vas deferens obstruct? And if so, when? And if it does, is that permanent? Meaning, if we do nothing and CF takes its course, are we committing him to, like Tyler, infertility and a need for, significant help in order to father a child, if that's what he wants to do in the future? Or will other CF problems arise? So either choice carries some uncertainty. I could see people choosing to stay off the ice because they're like, that's thin ice. We go out there, we're walking back cold and wet. Or maybe we miss out on our best day of ice fishing yet because or maybe we go get that fish because we had the courage to go out, test, see the ice is thick enough, and go out there. But how do we know if, I say we're on ice of uncertain thickness. I don't know if we're on thin ice or not. Nobody knows. So how do we know if we're on thin ice? We try to measure, and we try to learn from each other. Other people have, offered me very good guidance on what I can measure, what I can't measure, what else I might want to measure. Sticking with the ice analogy, if you poke too many holes to measure how thick it is, you could poke enough holes that you could actually fall through. So that always pulls me back to I'm taking care of a patient and I can't just draw a lab whenever I want to because I got to put another hole in his skin to get the labs. So even if we could get our hands on modulators, there's a cost. Like, who's going to pay for this? And this is where we get off label. Even if he was older, crushing the tablets is off label. It's not as off label as using it for a younger child, but it's still off label. And the dosage is unknown for infants. So in trying to figure out where we were going to go, I tried to estimate based on what we do know of ivacaftor and the dose per weight. And so we did some estimates, and in general, for the 2 doses that are approved for ETI, they work out to be a range up to about 5 milligrams per kilogram. For the ivacaftor component alone, if we look at younger kids, the ivacaftor, may go a little bit higher. Even in poster 693, the study in 2 to 5-year-olds, it wasn't up to 7 milligrams per kilogram. It went to 6 milligrams per kilogram. But we chose 5, and only because that was one line that crossed all the different bands there, all the way down to 5-kilo kids that are approved for ivacaftor if they've got a responsive mutation. So we used that as our starting point and kind of called it full dose. We did not drive straight out to the center of the ice. We went out a little bit and said, okay, where are we? How are we doing? But how do we even get out there? We wouldn't have gotten out there if, someone hadn't said, you can crush these pills. Families can actually weigh out milligrams of powder. They need some tools. They need a tool to weigh their child. They need a tool to weigh the powder, and they need a tool to make the powder. So we did a little shopping online and bought some tools. And the first dose we did in clinic, and we measured it out, and we compared our math, and, I have to thank the parents. This is all shared decision making, but, if you think people with CF are brave, wait till you meet their parents. They will do absolutely anything to help their kids. So even algebra. So now I'll get you some of his clinical data. And so for a period of about 2.5 months, he had no modulator. The blue arrow going back to the left, he was on modulator while he was in utero. So he had 9 months on it. And then a couple months without it because one, nothing bad had happened. 2, nothing good had happened. It wasn't approved for infants all of a sudden. And 3, we were still in the decision-making and information gathering part of the story. So what changed at 2.5 months? Because clearly he's still thriving. What really changed at that point was the report from the urologist. And Mom's brother actually has CF and has his only clinical feature is congenital absence of the bilateral vas. So this child's uncle was a big part of the family's decision making. So we started at a quarter dose and we ended up going up to a half dose, and that's where we are right now. So by half, that's 2.5 milligrams per kilogram based on the ivacaftor component. But looking at his fecal elastase, I watched his much more closely than I did for our first patients, in part because of Dr. Leisinger's experience and the ferret suggestion that without modulator, their pancreas may become suddenly inflamed and have a fulminant pancreatitis. At least from an elastase standpoint, his has been fine. It's never dipped down into the insufficiency range. When we looked at his serum lipase, going back to his very first labs, it was already showing that he had at least a chemical pancreatitis, not necessarily a clinical pancreatitis. He was asymptomatic, but his serum lipase was elevated. Even on a quarter dose, it dropped down into the normal range and dropped down rather quickly. And paired with the continued normal elastase, I don't think that's because his pancreas is failing. I think it's because his pancreas is no longer inflamed or obstructed. So why did we even go on to a half dose from there? Well, we went back to the row figure and thinking, well, the congenital absence could still have us with a borderline sweat. So maybe his vas could still be obstructing or at risk of obstruction. And on a quarter dose, his sweat chloride improved, but it only improved down to the 40s. So that's why we chose to go to a half dose, or 2.5 per kilo. And his most recent sweat on that was about 27, 28. There was a decimal point that I didn't include, but that's where he is now. We are hoping that by having his sweat down out of the range of CF, or even out of the borderline range, we don't know. We've got to wait 15 to 18 years to know if we've kept his vas functional or not, or if it will ever be functional. But his parents wanted to give him every opportunity for that. So for his continuing care, I want him on standard CF care. I'd like him on an approved modulator as soon as one's available. At a minimum, maybe one that tastes better than the ground up powder. He's a champ, he toughs it out. But he continues to get ophthalmology exams every 12 months. We actually did every 6 months in his first, well, we have done one at 6 months. He'll do another one at a year. He's not quite there yet. But I would love to be monitoring drug levels or pharmacokinetics. And I've had fantastic conversations with the labs at UAB and National Jewish and UNC, and none of them have permission to run samples for anyone under 2 years old. So I would love to get more information for the next person who has to walk this path. But for now, we're kind of walking it without drug levels or PK data. Continuing to monitor his elastase, now monthly, that he's on a modulator and his lipase isn't elevated, but we're going to keep monitoring that. And we're planning to repeat a sweat chloride in every 3 months. And then when he is older, like puberty we got to wait for, we're going to have his vas further evaluated for functionality. So I left the question and answer slide. I'm glad I'm last.
All right, thank you. If I could get Dr. Jane and Dr. Kazmarowski to come back up also. And unfortunately, we only have 2 chairs, so either 2 of you can stand and 1 not. But I'm also going to ask Natalie to go down into the audience so that she can ask questions or take questions down there. But I'll start here with the ones that came in. And actually, Natalie, one of these is for you, since your patients are here. So what they're asking about, and there are 2 similar questions regarding Paisley. And the questions are, were there any genetic mutations or dysfunction in Paisley? And really, like, what did they do about their testing beforehand, and what did they do with her testing after, is essentially what they're asking.
Yeah, the most, I think, popular question, we did leave this out, and my apologies. Geez, is that Darby, the mom, she did get genetic testing. That was our first thing when we met in clinic that day. As I said, first thing was we got to make sure you are not a carrier, which she was not. So therefore, to answer one of the second questions, they didn't test their embryos because she is not a carrier. And I can tell you Paisley's very healthy. There was no evidence that she has CF. I don't think they underwent genetic testing, but everything's A-okay with her.
Okay, thanks, Natalie. Okay, so the next question, and there is more than one pediatric person on this stage, and so I'll leave it to both of you to think about answering. So as a pediatrician, this is not a conversation I have that regularly. However, it is important and it is done as they become teenagers. What level of hope or what angle should we be taking for those patients who are currently transitioning in this rapidly evolving era?
I'll start and then I'll pass it over. I really appreciated Dr. Kazmarik's question to the patients. Have you thought about having children? That is a great way to introduce it. I'm going to start using that phrase. That's,
It's an easy one. I think that, sometimes we back into these conversations by let's take a complete sexual history. And I don't know how many of you trained when I did, but you start with asking, if they're having sex and who they're having sex with, and that feels like a lot. And I think that question around parenthood is a nice one because it doesn't just get at, okay, well, are you having sex and do we need to think about contraception if pregnancy is not in your immediate future plans? But it also gets at their hopes and their dreams and their ability to conceptualize this. I think that I have small children, they're 7 and 4, but they see me parent. So that is something that they're seeing and thinking about for their futures. So I think it's very appropriate to ask, developmentally appropriate to ask a 12, 13, 14-year-old that question and let them reflect. The beauty of that question too is that you can ask it in a self-visit where it's just you and your patient, but you can also ask it in front of their parent. And it's not a question that most parents are going to answer for them. So I think it's a way to really open that conversation. And really, a lot of the time it is getting at knowledge of what they understand about CF and reproductive health, which is something we all need to do. So thanks for that question. That was a good one.
And if anyone has verbal questions, I will come to you. Just raise your hand.
We actually do have a fair number online, and so until someone raises their hand, I'm going to keep going. So, Chris, this one I'm going to add to the question that's already in here, and this also, partly could be answered by you, Raksha. So, one person asked, how about the reports of cataracts in any infants, and do you have any suggestions? And then the other question along the lines of congenital defects and all of that. So you didn't see, can you just talk about what you saw in your baby and what you didn't see in your baby and how their development is coming along? Because that's one of the other questions I think that we're trying to answer in Mayflowers is the development of the child impacted by the mom taking modulators during pregnancy and or using it during breastfeeding?
All right, so this is the part where I'm going to not cry in this session, but you should see these kids. You should see them. There's nothing wrong with them. I can't say it more simply than that. They don't have to take enzymes. The little guy, he's not a great forward crawler, but he's good in reverse. The older one, our first patient, she's a thriving 2-year-old. She's just a joy. And we talk about CF, but we don't do a lot of treating of it because we don't have to.
Maybe I'll take it from the adult perspective in counseling the mothers. So actually, a few of us did just publish a case series in the journal CF just very recently on 3 infants born to mothers who are taking ETI, whose infants were found to have cataracts. Now, I think it's very important to note it was an association. We absolutely cannot deem that it was causal just off of these 3 case reports. But I think what you need to be aware of is there was preclinical studies in rat pups, particularly where the mother was exposed to ivacaftor, where the rat pups were noted to have non-congenital cataracts. And that's what led to the recommendation for children with CF to have cataract screening when started on modulator therapies. And I think last I checked, and I apologize if I'm incorrect, I think some of the data suggests maybe 1 in 25-ish of children 2 to 6 years of age have been reported to have cataracts after starting modulators, and maybe 1 in close to 200 of kids older than 12 years of age have been reported to have cataracts. So all I can tell you is my recommendations of what I tell my patients, and I'm not saying that this is, what everyone should do, but I am letting the mothers who are thinking of having children and or the ones who are currently pregnant know that there is this data out there, and I typically tell them that, soon after they've settled in and their baby is born, that they should have their baby screened for cataracts, and let the ophthalmologist know about this as well, because they may not be aware of this data. And then I tell them to continue yearly screening if they continue to stay on modulators while breastfeeding after that. And, and I think, again, with the Mayflower study, we are not at all, we're not changing any practice of what anybody is doing with their patients, but if people recommend to their patients to have the infants screened for cataracts, we will collect all that data, so we'll be able to gather what comes out of that study, but it is not being done uniformly across the mothers because we're not doing anything to change care as part of that study.
Another question that just popped up, and we recently, as the sharing group, created some guidelines that were sent out through the CF Foundation. So do you want to talk about the other things that are recommended besides just the cataracts?
I'm guessing the other part of that question is liver function testing, which is also come into question. And so Jen's correct that we can direct you to the CF Foundation very thoughtfully. Had some of us gather some recommendations, again, knowing that we don't have great data yet, but recommendations. And another one of those is liver function testing. So I think Erin Trimble, who's in the audience today, has had some nice publications about showing that these therapies, all three of them individually, and also Lumacaftor, actually all four of them, pass through the placenta and into breast milk. And in the original case report that he and others put out there on Lumiva in particular, I think there was a bump in LFTs noted in conjunction with infant exposure to these therapies when the mother was breastfeeding. Now, there was, I think, maybe a confounder of it. One of those times, the mother was also on an antibiotic simultaneously, but nonetheless, decreasing the dose decreased the liver function testing. Please correct me if I'm wrong on any of that. And so as a result, at least again in my practice, I am also telling the mothers to let their pediatricians know about this information and have the baby's LFTs checked soon after birth. And then I typically say every 3 months after that, just to ensure that there's no changes in that liver function occurring.
There was one other part of the guideline, and it's really based on Chris's experience. So can you talk a little bit about that? I think you brought the messages home, but really about the newborn screening and how we should think about changing that discussion and sweat testing and all that when the mom is taking modulators.
So yes, it was, like I said, it was our center coordinator who made sure the state knew we had one of our moms give birth to a child, and our state has been fantastic about running genetics no matter what the IRT was. All we have had to do is ask. But in other states who have an IRT cutoff, no matter what the cutoff is, if you've got the mom on modulators, it's quite possible that whether the infant has CF or not, the IRT won't be elevated. We've had 2 of them with that story, and there may be others around the country who also had that story. And if we look at our first patient, with her breastfeeding, if we hadn't run the genetics, probably would have been a year or more before we even wondered. Like, a pediatrician would not look at her growth curve and say, wonder if this kid's got CF. Not a chance. So definitely, and the only way we've come up with to do this is to have our center coordinator communicate with the state. So by keeping tabs on our adult patients who are expecting, knowing when they deliver, communicating with them beforehand so that, basically I believe the moms will just text their CF care team, hey, it's a girl, it's a boy. And then we send that on to the state of what date and, ask them to run the genetics for us.
So it sounds like, as always in CF, communication is really important with your adult team. So there are a couple, do you find one in the audience? Okay, go ahead, Natalie.
Hi there. What do you do in your centers when the mom is on ETI and in the case where they're continuing because let's say the baby has CF and it's been suggested that babies don't metabolize modulators as well and to dose reduce breast milk? Is that a standard suggestion that you give or?
So if I understand the question is for the mothers who have babies and they're breastfeeding, do we dose adjust that ETI to reduce the exposure to the baby? So I don't yet have any type of set practice from that regard. I don't think we know yet. And again, pharmacokinetics will be studied as part of Mayflowers in a very small subset of the population. Again, I can only tell you what I would suggest. And if there is a scenario where elevated liver function tests were noted or something else, then I would certainly do that. If the mom and baby, or the baby in particular, is doing fine, then I don't make a recommendation on dose adjustment for the mom at this point in my own personal practice.
Yeah, I would just say, and is Erin out there somewhere? I mean, the data in, you can talk a little bit about what do you see in breast milk compared to what do you see in plasma?
Yeah, so in a study that we did a couple years ago with Lumaiva and with ETI, we're both pretty similar, that breast milk concentrations were far lower than serum concentrations, and concentrations of ETI and for Lumaiva in the infant were actually multiple orders of magnitude lower than in the mom. So the restoration in a breastfeeding infant is just blows my mind. I do not understand that.
I think we had another question over here.
Hi, my question for Dr. Fortner. I'm in training. I'm just trying to understand one point in the case you discussed. Now, the baby has had the F508, right? Delta mutation, and she won't qualify for ivacaftor because she's not the one that qualifies. So she won't be qualified until she's 2, correct?
So the boy in this case has one F508 del and then an E92X, class 1 or premature stop mutation. So he won't even qualify for ETI, at least right now, until age 6.
So for Trikafta.
Right, and he
Okay.
wouldn't be eligible for any of the other modulators like Lumaiva or Taziva,
Okay.
because he doesn't have 2 of the Delta F508s.
So what made you go ahead and treat him? Is that like practice for any patient who doesn't qualify just to treat
Right.
his age?
So that was the shared decision making with his family and in consultation with other centers who had kids sort of withdraw after in utero exposure. What did we do? And it was a tough trip to go ahead and go out there and try this, but we know what CF does, and we don't like it.
Dr. Fortner, I have a quick question. I don't know if you mentioned how you actually got the Trikafta. Was it a little shaven off mom's, a shared dose?
The official answer is it fell off a truck. A family member has some Trikafta that they were willing to spare.
That's great. Does the E92X fall into the same category as G551D? Is that your reasoning for? No? Okay.
No, my understanding of that one is it's a class 1 premature stop, so no functional protein gets made.
Yeah, and I was just going to add, for those of you who haven't read Chris's first case, I think the point that he was alluding to earlier, and that maybe isn't clear if you haven't read all of John Engelhardt's work either, is that when baby ferrets are treated with ivacaftor throughout their mom's pregnancy, and when you suddenly take it away, they do rapidly develop pancreatic insufficiency, even though they were pancreatic insufficient, and in fact can develop pancreatitis, and that has happened in humans too who have had sudden withdrawal. So it isn't just a question of whether or not, oh, what about all these other babies who aren't being treated? There's a real risk to these babies of having sudden health decline if you don't treat them after they were exposed for 9 months to having pretty good CFTR function. I don't know if you want to add anything, Chris.
Well, in the off-label world, when we think about infants born to mothers who are addicted to narcotics, we monitor them for withdrawal, and we treat them to prevent that withdrawal. And if you ever look at the FDA insert on morphine, the safety and dosage in people under 18 has not been tested. So we just, in my mind, we couldn't not treat unless this family said we're not comfortable with the idea. But I was not prepared to let him withdraw from this if we had a chance of figuring out and going carefully and trying to figure out a dose. And again, we started low, and we started low based on feedback from Dr. St. Peter's patient, and we worked our way up.
So Tracy, you started to talk about this a little bit earlier, and you gave us a really good example of how you might start this conversation. But what the questioner is asking is, in the setting of pediatric folks not being so comfortable talking about sex at all, how do you get teams to even start thinking about having these conversations? I know you've done a lot of work on that.
I think about this a lot because, a lot of us went into pulmonology to not deal with the things down there. So I think that there's a couple resources that the CF Foundation has that are excellent, and they span beyond reproductive health conversations. I can see several of my partnerships for, oh God, I'm not even saying the word correctly. PEP training is the answer. And I think that if your teams have undergone PEP training, you'll know that the skills that are taught there really teach you to open these conversations. And as somebody once said to me in an interview, I don't ask that question. I don't want to open that can of worms. This allows you to ask the question, open that can of worms, unpack what you're seeing, and then make a plan together. Many times when people tell me things, my answer is, I don't know what the next step is, but we're going to figure it out. And we're going to come up with a plan. So I think there's a couple things that you can do. One is to really look into the PEP training through the CF Foundation for you and your team. I think that can be really helpful. And two is, when you don't know, have a team of people that you've connected with that you can ask. So identify a maternal fetal medicine doc that understands modern CF. One of the patients in one of the focus groups we did many years ago said it was really disconcerting when she sought reproductive health care because the OB-GYN that she went to looked at her and said, "You're 35, how are you still alive? You have CF." And that's not okay. So it's on us as CF providers to really get out there and share this message that the CF that you learned about in med school is not the reality now. And I think that having a cohort of people in adolescent medicine, OB-GYN, Urogyn, fertility, urology, can really be helpful for you as a team to not feel stranded when things come up where you want to refer, but also for your patients so they have that experience where they're sent somewhere that really understands and reflects on the modern era of CF care.
I wanted to point out there was on the discussion tab instead of the question tab, which I know who it came from. It was concerning mental health, so thank you, Thomas, for adding that point in. And the point was when Tyler talked about being very depressed, and that Thomas is our mental health coordinator at Hopkins and basically just said it needs to be like a really parenting when you have CF, there needs to be a multi-support there to kind of help that person with CF do everything they need to do for himself, herself, and their child. Am I saying that right, Thomas?
So one of the things that I'm seeing, I'm starting to see a lot of patients who are having CF babies, and they're having them close together because this window is open for them to have children. But one of the things that I'm finding is a co-occurrence of depression, postpartum depression, and then really difficulty transitioning to a multi-generational support system. And so a lot of the support that we do looks at informational, practical, or emotional support. But as they move further and further in the lifespan, they're going to fall into a sweet spot where they're going to have to care for their parents and their children. And this is a different paradigm for CF patients. So I want to raise the awareness of that as somebody on the front lines working with Natalie and the team. I'm seeing it already. So we have to begin to prepare the dialogue for them to understand how, when their current support systems begin to shift and decline, how they're going to have to move and operate as well. So thank you for that.
Thank you. Thank you, Thomas.
Natalie, we have one more question. I think we have time for one short question.
Thank you all so much for all of your work. It's a fascinating session. I wanted to ask about your experience in clinics, about maybe risk factors outside of which you've already presented, but hemoptysis, fungal disease, NTM, and pregnancy in the context of hemp therapy as well. Is there anything that's coming through? Because we're getting those questions, and it would just be lovely to see a signal, perhaps.
Yeah, I mean, that's a great question, and I can only tell you my anecdotal experience. I mean, overall, the nice thing for our clinic is we have seen a dramatic decrease in hemoptysis since the introduction of ETI. So that's become less of a barrier. But having said that, if we have somebody with chronic hemoptysis, we generally counsel them that it is, you know, you have to be very careful because we know the plasma volume increases with pregnancy and we don't know the impact, and there's not been any great data that I'm aware of, but we counsel them on we think that's concerning and generally discourage it. I mean, I don't want to say that blanket and whole, but that's the case. And then when it comes to non-tuberculous mycobacterium, I think the key, and we have a fairly high prevalence where I am in the South, is that the key is that we try to find a place where they're stable and that they're not going to need therapy for the next year or two. And that's very challenging because, you know, several of those therapies are potentially unsafe in pregnancy and will have interactions with ETI and a number of other things, nor do we want them to be on IV therapies while they're pregnant, particularly aminoglycosides throughout their pregnancy. But, you know, if there is any signal that their health is in a place where we think that might occur, we tend to discourage it. But we have a lot of people that have been stable with their NTM for years. And if it, you know, we let them know there is this possibility. And if you make this choice, we will probably have to hold off on this NTM therapy until after you deliver, which is a big, you know, concern. And those are, again, we have long conversations about it. But don't completely discourage them just because they're colonized. The discouraging really becomes if we foresee that their health is giving us a signal that it's not stable. I don't know if anyone else wants to share their practice, but.
The only thing I was going to add is that the study that Raksha presented earlier with all of the retrospective data, that is going to be tied to the registry, so we may have some more data going forward about subpopulations within that population that she presented earlier. So. Thank you very much. I wanted to say thank you to the audience. There were so many questions we didn't get to, but thank you to all the speakers for a great session.